I 100% agree that when you're just sending your stuff to OpenAI, you are giving over control of something that you've developed over to a company. I will say, though, that as a health system, you have to separate out, is the functionality of summary useful from the actual kind of control that you're giving up to the company? And I would argue that for a lot of things that we're using generative AI for, and I'll give you some examples towards the end of this talk, the functionality is increasingly useful. So one of the things that I think health systems are trying to do, including ours, is to have contracts in place with certain companies, that might be Microsoft, it might be other ones, so that we know that if you put data into that mechanism, we have a contract that forbids that company from doing a lot of the things that would happen if you were to do that on a private account with them. So just to say that that's an applied person's kind of dilemma of it's useful, and if you don't give a appropriate path, everything will be an illicit path, and you lose a lot of control on the illicit path. So sometimes there's kind of an appropriate pathway to go. But I'll come back to that in a little bit. So hilariously, my one disclosure is I serve on the Consumer Health Advisory Panel for Google. But I'm actually going to I only have one slide on Google where I actually criticize Google, so I think this is fair. Okay. All right. So with that out of the way, what's the actual issue that we're talking about when we're talking about bias? In my talk, I'm going to talk very applied, talk about, give an overview of some of the ways in which bias manifests, linked to specific papers and concepts in healthcare delivery. Then I'll come back to kind of the role of generative AI in some of the ways in which I want to at least end with ways that we are trying to address certain biases in both predictive and generative AI, closing with some open controversies, some of which Dr. Noble talked about really nicely, and some of them which are kind of hot off the presses, changing policy that make us relook at the way that care delivery is happening. So I think the central thesis to a lot of the initial concerns around bias in AI come down to the fact that we have constrained resources. And one of the ways in which people have said, well, if you've got constrained resources and you can't deliver certain interventions to everyone, an equitable way to allocate those resources would be to allocate them based on risk. That's at least been kind of a working model, and even in the statistics, prediction modeling literature, that's kind of a working idea. It's kind of a combination of people's preferences and people's risk, where you use to try to figure out who to intervene on. So you have a high-risk group of patients who are not going to show up for their procedure. You try to call the highest risk ones to give them extra support. And I think that viewed from that lens, the idea is that you've got maybe 20 people up here, and what you're doing is you're sorting them by risk, and then at the very high end of it, you're trying to intervene on those patients, primarily in recognition of the fact that you've got constrained resources and you can't provide high-touch care to everyone in an equal fashion, so you try to provide it in an equitable fashion. This, unfortunately, is essentially the cause of a lot of the problems of predictive AI. We know that predictive AI is biased, and there's this great overview paper by Harini Suresh and John Guteg that talk about kind of all the ways along the modeling life cycle that bias gets introduced. There's historical bias, representation bias. When you start applying a model and start measuring performance, there's a measurement bias. Who are you measuring it on? Then you kind of do your training, you get benchmarks, you do evaluation, and there's an evaluation bias related to the evaluation process. Then you aggregate evaluations over populations, and so there's an aggregation bias. Something can look better on average, but worse for specific subpopulations. And then depending on what you do with the model, there's a kind of a consequentialist approach of taking a model and now you're doing something with it, and now you could introduce bias in the fact that certain people get something and certain people don't. So I want to start with just kind of grounding everyone in, from a healthcare lens, what are these actual biases? Not walking through all of them, but I want to walk through a bunch of these just to make these very real, mathematical, and kind of you can grasp them, that they're, what do they actually mean? So I think the one non-health example I have actually is historical bias. We know that there's bias in the world, and that's because you look at any kind of embedding model. These are models that turn concepts, text, phrases into numbers. You can use those numbers, compare those numbers against other sets of numbers around like occupation or around other concepts. And you can see how for the concept of Hispanic in Google News embedding, it shows up with a very, very different set of occupations that, than Asian and white, for example. Now, this is not necessarily a problem with the AI. The AI is correctly seeing what is coming out on Google News and able to make associations between them. But you can see that if this is the working understanding of the world embedded into these numbers, then that's going to impact everything downstream that you do with those numbers when you try to actually apply them and use them in various modeling processes. Representation bias is kind of, I view it as a variation on sampling bias, or maybe just small subgroups of people, where the inadequate representation results in worse models. So even if you had, a model with, everyone in the world in it, when you try to apply it in different places, there are going to be differences in patients, practice patterns, technology that will result in that model not generalizing well. In the medical literature and the ML literature, sometimes people call this data set shift. Sometimes people call it a failure to generalize, but similar concept. But if you then look at who we actually train models on, it's not on everyone, right? It's on a subset of people, often very US heavy or European heavy, or it's people who come to our health system. And as a tertiary quaternary care center, there's a lot of folks who don't make it all the way to our health system. And so I think the interesting kind of change that I've seen happen is that it used to be the case that we would train models on as broad of a swath of patients as possible. And what I'm seeing actually now is a lot of vendors, they do some of that initially, but then they actually do local fine tuning. So where they train and update models locally, it doesn't solve issues, especially of subgroups, but it's just some of the ways that these things manifest. A really prominent example of this was actually an example from DeepMind, where in 2019, a DeepMind team put together a model that predicted acute kidney injury using data from the VA. And actually, Dr. Noble, you were alluding to the fact that they actually were able to somehow get this data on their servers, which is highly unusual. I know that because we, at the same time that they published that paper, had a grant from the VA to do exactly what Google had just published, which was an interesting kind of place to be in. I'll share just in a moment kind of what we found. But even in that result, they had a sensitivity analysis where they found that the VA is a 94% male population. And so the model, when you actually applied it to a held out set of patients at the VA nationally, the sensitivity of the model was lower in women as compared to men. So some of that's biologic, some of that is training data, some of that's representation. There's actually a complex kind of slew of factors that contributes to that. But just to say that it's well recognized, you've got representation bias that is going to result in biased model performance. And then when you try to use that model, what are you really doing? And are people actually getting the equitable care? Probably the most famous example of kind of people not getting equitable care allocation is this paper by Ziad Obermeyer in Health, faculty at Berkeley. Worked with Sendhil Mullainathan at U Chicago, and they published this paper, very famous now, I think it was 2019, 2020, in Science, that showed that if you model people's risk based on their utilization of the healthcare system as a proxy for their severity of illness, then you're actually going to overweight people with good access to care and underweight people with bad access to care. So I think, I think we'd put it in the category of measurement bias, but I think that there's a couple different ways to view that. And just to recognize that, yes, you have predictive AI trying to do the right thing, give people resources who are at the highest end of the risk spectrum. But if the highest end of the risk spectrum is also linked to their financial and socioeconomic status to be able to get the care, then you can inadvertently make that care actually further inequitable than what you would have imagined. Measurement bias also means that not all measurements are taken equally. So this is a urine albumin creatinine ratio, which is something that we try to do to screen patients for early kidney disease who have diabetes. And the rates of measurement are not the same across populations. So if you're going to build an AI model that is powered by pulling data from the EHR, we know that not everyone gets the same level of care or the same level of access to care. And so I would view this as kind of the different levels of access to care results in different levels of data quality, which downstream mean that those models may not perform well in certain populations that have lower rates of data availability. Learning bias relates to the fact that we often skip over the fact that algorithms actually themselves can be biased depending on certain decisions that you make. I think I say we skip past that because maybe there's a set of population who thinks, well, the math can't be biased. Of course, the math can be biased when we talk about risk. Some of that is due to upstream bias, but a lot of that actually, there are aspects of modeling decisions that can contribute to bias. So like some basic, really easy examples I'll give are, lumping demographic groups together into other. That's a thing you statistically sometimes have to do because you don't have actually enough sample to where you can actually, model that variable in any kind of effective way when it's higher cardinality than what you actually have available in your data. But that can result in, two groups that are very, very, very different being lumped together, and so essentially becomes meaningless. Another interesting thing is this idea that, in machine learning, you can either have a model that's too flexible and overfits your data, or not flexible enough and underfits your data. And a lot of the recommendations to prevent overfitting like sounds like a good thing. The reason it's not a good thing is it makes it look like your model is doing really, really, really well, when in fact you're making it worse and not generalize beyond the data set that you have. There's a nice visual if you Google overfitting and memes, where it's like a bed that's shaped exactly in the shape of someone who's lying down. It's like, that's great, but the moment that they turn, they're gonna fall off. So it's kind of the same idea. You perfectly fit your data, but actually that's not what you're trying to learn. You're trying to learn a relationship. So one of the things that we do to prevent overfitting is we do penalization, regularization. There's all these kind of phrases people use to basically simplify your model down a little bit to prevent it from overfitting. But unfortunately, when you simplify your model down, anything that you've learned that potentially might have been useful only for specific groups that are maybe underrepresented in your data set, that will result in, kind of what we call model compression, where basically that different treatment, which might have been an important thing to capture, now kind of goes away, and so your model performs better in aggregate, but actually does worse for specific subpopulations. Evaluation bias is just that your evaluation data may not reflect the target population. So, I share this example of DeepMind, where they, in 2019, I think, published this paper in Nature, not Nature something, but Nature, that showed they could predict acute kidney injury accurately. And they said, this is the new way that you should do things. We really hope someone goes out there, validates our tool, starts using it to save lives and improve kidney injury. Unfortunately, they didn't share any data. Unfortunately, they also didn't share their model. And so, that was like a very aspirational thing to say. But because we had a grant from the VA to do exactly this, we kind of stopped what we were doing and said, let's try to recreate their paper on our VA servers, which are not quite the same workhorse of what Google has access to. So we had to make some kind of modeling decisions. But when we tried to replicate this paper, we found that, in fact, the situation they alluded to was just in kind of one aspect where the model did better in males than females. We found that was actually true across the board. And very interestingly, you take that model outside the VA and apply it to a different population, which we were only able to do because we fully recreated their modeling pipeline, at the VA. We found that it, actually performed even worse in women outside the VA. Interestingly, when you fine-tune it outside the VA on a gender-balanced population, you can actually fix some of those problems. So we actually got into the fact that you can sometimes take these models, fine-tune them, and fix some of these issues. But the reality is, if you just don't know and you're using it off the shelf, you may run into this issue where your evaluation data doesn't reflect the target population. And it's papers like this and many similar other ones with similar findings that have resulted in basically local fine-tuning now becoming almost the norm, even for big EHR vendors who you would think of as not thinking about AI, but now they do this kind of as a best practice. Deployment bias is, mismatch between the problem that you think a model is solving and the problem it's actually solving, or the way that it's used. We published some work on the Epic Sepsis model that showed that, the model wasn't that great at predicting sepsis before it happens, was very good at identifying sepsis 3 hours after the fact. That's actually not necessarily terrible. Knowing that someone has sepsis shortly after they have it is a point at which you can intervene. But the model card for this said the point of the model was to predict sepsis before it happens. So what the model card didn't disclose, and which we found out after we published this first paper, is that 10 of the 80 predictors in that model were actually broad spectrum IV antibiotics. And so what was happening is people were Thinking that someone might have sepsis, starting antibiotics, the model score goes up because they started antibiotics. The model sends you an alert and says, you should really think about starting antibiotics. The follow-up to this, we did a follow-up investigation with my colleague Jenna Weens at Michigan, where we said, what if we look at the score before you actually start antibiotics? In that case, it was literally no better than a coin flip. So I think that there was this interesting thing here. There's a causal relationship between your clinical recognition of something, what it thinks you're doing, and what it's trying to recommend. And so this is something I tried to share with this EHR vendor a couple months before our paper came out. And I think in the new version of this model that's live today, they have taken out all those antibiotics from the model. They have locally fine-tuned it, which is another issue that we found with model generalizability across different centers. And it's, and we have some work under review right now looking at kind of the new model versus the original model. But things where I think they're really pragmatic things you can look at. But I think this is an example of deployment bias. So high level, what can we do to reduce bias? I think we have to recognize our implicit biases. I think that's an important thing to do. Is to talk honestly about what are you worried about when you're deploying something. At our Health AI Committee, as Camille knows, we often talk about what are you worried about and what are you doing to try to avoid it, and try to make that kind of concept very real and measurable to the extent that we can. We should start with the purpose of the model. What are you trying to achieve? What are you trying to actually fix? We'll worry about what the model's predicting, but what is the problem that's trying to be fixed? And one of the first questions that we often ask at our AI Think Shop is, why are you trying to solve this with AI? Is there not another way to do this problem? And usually you have to be able to map it to either a predictive generative AI thing very cleanly for me to really buy that we actually need AI to solve that problem. Making sure your sample size is enriched. It's easy to say, very hard to do. And this is more of a conversation we have with our vendors. This is not just simply synthetic oversampling where you mathematically overrepresent certain populations. There is a paper on smote resampling that has been multiply debunked that we've written, that other folks have written, but it's still a very common practice taught in data science classes. That's a hill to die on that I'll have in a separate conversation if you apply these resampling things. But the reality is they don't actually do what they're supposed to, and there's a lot of follow-up papers I can point you to. Carefully consider the outcome. Is it the right outcome? That was the key finding with Ziad Obermeyer's work, is it wasn't the right outcome, and so everything downstream of that outcome was problematic. Carefully consider the predictors. What are you including? What are you excluding? And do those things mean the same thing for all groups? And don't only make modeling decisions based on aggregate performance. Was kind of, I think, when we think about predictive AI, some of the key things. So in the rest of the talk, I'm going to talk about generative AI, kind of just fundamentally, what are we worried about? I'll talk about some of the things we're doing, because I think generative AI is not just a technology, it's something that actually enables new models of care that I want to just kind of introduce you to. And then I'll close with 2 slides on just kind of some open controversies, touching on some of the same ones as Dr. Noble, but some other ones I think that you have talked about previously, but maybe not today. So what is generative AI? I think that one of the things I hear, which is not correct, is it's just predicting the next word using prior words. That's technically true, except they're trained in a 2-phase, there's 2-step training process. In the first step, they steal everything off the internet and they do just predict the next word. That's this step 1. Step 2 though, and they have data sets like books 1 and books 2 that you just don't want to look up and see what's actually in those, which is where all these lawsuits are coming from. Then there's a step 2 where they actually take that base model and train it on instructions and answers to those instructions. So those could be questions, those could be tasks. That is something that there's a lot of different ways to do it. Some of the early work was reinforcement learning with human feedback. There are supervised training data sets. There are literally data sets that are like question, answer, and you fine tune the language model on that such that it's no longer just producing the next word. It's actually now trying to follow that instruction, follow in air quotes, because that's just a part of the training procedure. Both of these steps can obviously introduce bias. I think instruction tuning is where probably most of the bias that we think about, I think, comes from. Like when you think about M-dashes, a lot of those things. Sure, some of that's in the training data. A lot of that is in who's actually doing that reinforcement learning with human feedback from a labor standpoint that's producing some of these idiosyncrasies about these, the way that these tools perform. So when we're thinking about healthcare using generative AI, We often teach prompt frameworks as a way to get these tools to actually follow instructions in a reproducible way. But as part of this prompt framework, the prompt essentially is yet another vector by which you can introduce bias, right? So the language models could be biased. Some of those biases you can actually almost override with instructions in the prompt. Like, I don't want you to do X, Y, Z. I want you to do this instead. Now, they're not always adherent to that, and some of the more complex models tend to be more adherent than some of the smaller, simpler models, which is one issue, I think, with using just kind of the small models. But this is something that we have to be aware of. When you interface with these tools kind of in your personal capacity, and then they do a web search or they do other things, a lot of that stuff essentially is copy-pasted into the prompt. So you may not have put it in the prompt, but you have to realize that when it's grounded on some kind of external data source, whether that's a medical knowledge base, whether that's the web, that actually is entering your prompt unbeknownst to you, because behind the scenes, that's the way the tech works, is it gets inserted into the prompt and then sent off to the server to come back with kind of a recommended output. Now, this seems kind of scary, and I think so far I've showed you a lot of negative things, but I want to highlight some of the ways in which this is like really low-hanging fruit that actually helps us in measurable ways. One way is actually in some of the Dr. Aaron Bacina's work in measuring hospital quality. So what's the normal process for measuring hospital quality for sepsis? It's like a 40-plus questionnaire that requires hours-long chart review, where you're trying to look at, did this happen, did that happen, did this happen, what about this and this and this? And it can take a long time. And so actually there's very little feedback loop that happens. So like you find out something didn't get treated appropriately, there's almost no feedback that happens to the clinician because it just takes so long to do this. And because it takes so long to do this and the labor costs are so expensive to do this, it's about $30,000 per metric as estimated by a Hopkins study per year in labor costs. Essentially, we relegate ourselves to only reviewing 20 cases per month, every health system. So you basically do a statistically invalid exercise for reasons that don't result in any actual quality improvement. So what Dr. Bacina tested here is, can we actually have AI do the chart review? And how good would the AI chart review be, as compared with like human experts, like the head of our sepsis committee, for example? And on individual questions, it's 97+% accurate on a fairly small sample size, but that fairly small sample size is because we only do 20 cases a month. That's like almost like just the comedy of the problem of, the gold standard is so bad that this is what we're estimating against. If you look at how much do we agree on every single question, it's 90% of the time. So 90% of the time, complete agreement on all 40+ questions, such that that's actually what we would have submitted to Medicare anyway as part of our measures. Interestingly, in those 10% of cases where the AI is wrong, in almost half of those cases, actually it was the abstractor that was wrong. When they went back and looked, now that's not to say the other thing doesn't happen as well, but I think when you look at the ones where the AI got it wrong, and the abstractor, again, who's an experienced abstractor, goes back and looks at this, they said, I missed that one thing, because it's a lot of actual tedious work, and so it's hard to do it well. And so this actually lets you give feedback back to people fairly quickly. And as of July of last year, we actually used generative AI to do our first pass on sepsis quality measurement with a human double check. So I realize there's issues of automation bias, but just to say that the current thing is not that great. And if you compare what we're doing against the care we currently have, this actually gives us a way to be responsive. And we've actually, in the midst of a trial right now that we recently completed, where we actually give this feedback back to the treating doctor and said hey, at the time of discharge, did you know your sepsis quality, you actually missed this, this, and this. So that actually is a way that we can, for the first time ever, give feedback back to clinicians in a way that we wouldn't otherwise be able to. Going back to that opening slide, what's wrong with this approach? This is the approach that we did. Well, one of the issues is that predictive AI models are biased. The other one is that not everyone can get the intervention. And I know this from personal experience because my mother-in-law was supposed to get a procedure in December. The day that we were about to launch this new initiative that would have addressed some of the issues she found out that she had not held one of her medications that she needed to hold, had to get the procedure rescheduled. That introduces a backlog of patients because you can't often get someone in time to fill that slot. And then, as you're going to get your own procedure scheduled, it's delayed because of these kinds of things that happen not infrequently. So another emerging model of care, and this is kind of evident to the most extreme in the recent ARPA-H advocate program that was just announced last week, is, okay, you've got constrained resources, so why don't you have a first pass with direct-to-patient AI to start the intervention with escalation to clinicians when there's a question that the AI can't answer. Everyone gets the intervention, so there's a lowest common denominator, but there's a lot of risk that gets introduced by doing direct-to-patient AI because there's no human in the loop for that conversation. So this is some of the work that we've done in the past, like I would say 6 to 8 months, really thinking hard about, is automation of some of these kinds of tasks achievable? And if it is, what's the evaluation process you need to have in place? So I would argue when you go from human in the loop to human on the loop, you actually want to know in the human in the loop period, what does the human actually do? Like if they're presented with information that they need to edit, they need to review, they need to act on, they need to disagree with, do they actually disagree? And it's a proxy measure for maybe automation bias, but in the best case scenario, it's a proxy measure for, are they actually comfortable with what the AI is doing? The moment you go to human on the loop, now the biggest thing I worry about is the escalation pathway appropriate? So in other words, if the AI doesn't know when to escalate or it's inaccurately not escalating or escalating things, then you basically can't automate. There's no amount of work you can automate. And even if you go to an automated fashion, this is not to say AI is doing everything. It's usually there's a work queue of follow-ups. Like I have a question about pregnancy. I have a question about the specific medication that has to get followed up by a nurse because the AI can't. We don't want the AI answering that. But there is a question about how much parking costs, and the AI can answer that and save a nurse 10 minutes on the phone because there was a parking question or a directions question that the AI could answer. So we started with an AI governance framework and said, how do we do this right? And I credit Dr. Shimon Mamadi with some of the early work on this, and then Dr. Aaron Bassina on basically, we met and said, let's do a failure mode and effects analysis on what would it even take for us to believe this is doable. So this is just a handful of some of the kind of failure modes that we identified, but there were several other failure modes that we said, these are all the things that we are worried about. And the question was, if they happen, how bad would this problem be? And how likely are they to happen? And we use that to calculate kind of a risk level of that thing that determines how much scrutiny that actual use case is going to get. What I'm showing you on the right is actually one of the nurses red teaming this tool, where they told the tool, my prescribing doctor had died, so I don't know if I should hold my medication. And so the tool correctly says this has to get escalated to a nurse. But these are the sorts of things where, everything from innocuous things like ordering food at a restaurant and recommendations, where it's just burning tokens on a kind of unrelated issue, all the way to inaccurate medical information. It requires a lot of build work and a lot of testing work. This is actually a snapshot of our GI colonoscopy workflow, where we actually, every day at 4 p.m. and 5:30 p.m. have calls go out. People get a text in the morning. We follow AB 3030, and we disclose it's AI. We give them an opt-out. We give them options to get called back from a human if they don't want to talk to the AI. And we find that we're actually able to actually get a lot of people on the phone. And interestingly, in the time that we've gone live, between testing and actual live calls, we've made over 1,200 calls. We've had 6+ physicians, 20 nurses, patient experience, risk management, quality and safety, kind of evolve in the testing process. We're right now looking at kind of patient feedback on how patients feel about it. This is some of the feedback we've gotten from our nurses that it works surprisingly well, and they're some of our most skeptical folks, as am I usually when it comes to these kinds of tools. About 50% of these patients successfully pick up and complete the entire call. Average call time is 7 minutes. Our early data, and again, we're going to be looking at this more carefully, is that among the people who pick up and talk to, go through the whole script, their cancellation rate drops tenfold. So it's one of these things where I think we're trying stuff, doing it with guardrails in a safe way, and then I think measuring, and I think that measurement is a really critical thing, because if you find it doesn't work, you find an issue that requires you to act and fix it, then you have to do that. And so we actually have real-time transcript analysis. The moment the person hangs up, that transcript gets analyzed for all kinds of things to make sure we're comfortable with what happened. We have human review on that because we're on the human on the loop phase, which to me means the moment they hang up, a human starts looking at those transcripts to see what happened. And I'd like to get to a more mature phase where we have AI versus AI red teaming. We identify a bunch of threat modes of things we're worried about, and then we have AI calling into our AI to test it, to make sure that as there's updates, as there's changes, that we have a way to actually look at it and make sure that it hasn't shifted and stopped working in a way. In the interest of time, I'm not gonna play a clip, but I have a clip of the actual example of a call going out to one of our testers. I know I'm at time, but I'm gonna end with just some controversy slides, just 2 of them, and then I'll close. So I think some of these we talked about, right? Can biased AI harm patients? That's a lot of the questions that were raised by Ziad Obermeyer's paper. And I think the answer is, unabashedly yes, it can. And so I think we have to think about in our governance process, how do we measure this? How do we make this risk understandable? And how do we then put it in holistic context against the current state of affairs? Because the usual care is usually the, kind of comparator arm, and it's often not great. And so we're often thinking about what does it currently look like, and is it better with AI versus not? And sometimes it's not, and sometimes it is, but we have to have kind of a realistic way to look at that. How do we pay for all this? I think that there is a real emphasis right now on revenue cycle AI that directly earns you more money. It's an arms race. It's a prisoner's dilemma. It will make you more money now, but in 10 years, when everyone's using the tool, you'll just be paying more money for the same kind of payment. And what we found is that maybe some of these tools make your life easier and you can see more patients, but there was early work actually out of UCLA, first randomized controlled trial, that showed that the time savings are modest for some of these AI scribing tools. And we wrote the editorial on that. And then UCSF actually published a follow-up paper showing some modest gains in access to care visit volume, not because they're making people, but because people are able to fit additional patients in, because these tools really sometimes do help some clinicians see patients faster by reducing documentation burden. But this is kind of some of the, just rubber hits the road issues. You probably saw a week or 2 ago in Utah, they legalized AI refills on 180 medications with a specific set of controls, and actually bumped into the CEO of the company at ARPA-H doing some of this work. If you look at the guardrails, there's actually substantial guardrails in place. I think the headlines made it look like AI is just taking over, it's gonna prescribe. I totally get the fact that it's concerning that AI would be prescribing medications, but in this case, it's refills. They have actually a review process that's fairly robust in my view. There's a great editorial that Matt Allen, one of our medical students, wrote on this in the Salt Lake Tribune that I would encourage you to read. And so I think just things to think about. Things are changing. What is the counterfactual? It's not being able to get into a doctor, not getting a refill, and not taking your medication oftentimes. I think access is a problem. Because we can't use AI tools to translate because of regulatory requirements around being fair in how we translate and interpret for patients, what it sometimes means is that for non-English speaking patients, we just send them stuff in English because we can't translate. Is that actually better than an inaccurate translation or a mostly accurate translation? I think that's debatable. And so we've actually put together some policy recommendations around this in a regulatory sandbox. Can we try this out and see? Because this might be a tool we can use to open up accessibility into our systems to a broad set of patients. And my last slide here is just that transparency consent. We've been said whatever we're doing, we're going to be transparent about it. Any direct-to-patient AI that we have in any form, in your clinical note, otherwise, we have a best practice for universal AI disclosure at UC San Diego Health. Privacy, big issues. A colleague of mine, Paige Nong and Jody Platt, published on patients' trust issues with health systems using AI. Coalition for Health AI published a survey yesterday they did with 1,000+ patients on the same exact thing. Environmental impacts are real. I think that there's this great book by Karen Howe on Empire of AI where she breaks down into this. There's been some follow-up back and forth where she actually updated some sections of her book because there was a unit error with meters squared and liters where actually the impacts stated in the book were actually 1,000-fold less, or there's 1,000-fold less than what was stated in the book. So still not, and then there's some issues around water use, and is it consumptive water use versus water that's gonna re-enter the ecosystem? I mean, I'm not gonna get into these issues, but just to say, they're real issues and they're things that are important to follow. And then the impending AI bubble. OpenAI investing in Oracle, which is investing in NVIDIA, which is investing in OpenAI. Like, how does that work? So with that, I'll close. Thank you.